Hello, everyone. Hello, everyone. Thank you and welcome to our Research Connect series. My name is Todd Hopman, a CDTRP Ph.D. I will be facilitating today's webinar. My connection to this world is next month it will be 14 years since I had a living kidney transplant, and I've been on dialysis. I've been through that journey. And then I guess just to quickly mention my day job, I'm the communications manager at the Vancouver Aquarium. So I get the fortune of telling the stories of amazing and adorable animals all the time. So first, first off, I would like to acknowledge that CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Ojibwe, Inuit, and many others, whose histories, languages, and cultures continue to influence our vibrant community. And I am joining today from the unceded and traditional territories of the Squamish, Tsleil-Waututh, and Musqueam peoples. I encourage each and every one of you to write your land acknowledgement in the chat box. We would like to thank and acknowledge AstraZeneca and CIHR, whose generous support we could not have had with these sessions without. Before I dive into the main content, I'll pass it to Erica for general CDTRP updates.
Thank you, Todd. Today I have two announcements for you all. Dr. Caroline Tate is the head of our Indigenous platform, and we're excited to be announcing that she'll be hosting a Café Scientifique webinar called Pathways to Truth and Reconciliation in Organ Donation and Transplantation. This event will be held on February 27th from 12 p.m. to 4 p.m. Eastern. Dr. Tate will be focusing on Indigenous people within Canada, and then again from 6 p.m. to 8 p.m. she'll be focusing on Indigenous people outside of Canada, specifically Australia and New Zealand. This event is free, and I will provide the registration link in the chat box. The second announcement is the Save the Day for our Ph.D. Forum. This year's Ph.D. Forum, Patient, Family, and Donor Research Forum, will be held virtually on June 13th and 14th. Registration will be free and can be done through our website. The link to register will be live soon, so keep your eyes out for that. Thank you.
Before I introduce our speakers, I have a few housekeeping notes. Today's session is recorded and posted on the CDTRP website and YouTube channel. During the presentation, please keep your mics off. And if you have any questions or comments, you can raise your hand using the raise hand button or type them in the comment section. I'm awfully pleased to introduce our presenters, Dr. Marie-Chantal and Ruth Sapir, and I apologize, Ruth, for the mispronunciation of your name. So first of all, Dr. Marie-Chantal Fortin is a transplant nephrologist and researcher at the Centre de Hospital de University of Montreal. And again, forgive me, I'm an Anglophone from Vancouver, so that was a terrible pronunciation. And also a professor at the Faculty of Medicine at the University de Montreal. She received her medical degree from the University de Sherbrooke, I should say. She completed her nephrology residency at the University de Montreal and completed her PhD in bioethics in 2008, also at the University de Montreal. Her research interests are related to transplantation ethics, patient and researcher partnership in research and clinical care. And then our second speaker, who, because I am terrible at pronunciation, I think I was going to introduce her as the saffron goddess of the forest, because that's what her name means, to my understanding. She is a clinical scientist at the University of McGill Health Center, an associate professor in the Division of Nephrology and Multi-Organ Program at McGill University in Montreal. She completed her subspecialty training in nephrology and kidney transplantation at the University of Toronto. She also completed the Eliot Phillipson Clinical Scientist Program, the Royal College of Physicians and Surgeons of Canada Clinician Investigator Program, where she undertook a Ph.D. in clinical epidemiology and healthcare research. Her doctoral studies focused on pathogens, diagnosis, prognosis of antibody injury secondary to the production of anti-human antigen antibodies in kidney transplantation recipients and candidates. We're all very excited. I will send it to you now.
Thank you so much, Todd. On behalf of Marie-Chantal and myself, I thank CDTRP for organizing the meeting and to you for this kind introduction. I'll start by sharing some of the experiences that we have with regards to kidney transplant professionals, transplant patients, and candidates' perspectives on precision medicine. These are both of our disclosures. And I'll proceed with sharing the outline. We will start by introducing the concept of precision medicine, and pertinent to our talk is establishment of molecular compatibility. We will proceed with discussing ethical issues related to precision medicine and molecular compatibility, and transplant professionals and patients' perspectives on this topic. We will then conclude with a path forward on implementation of molecular compatibility in the context of organ allocation, thanks to the lessons learned from our experience through the Genome Canada Transplant Consortium. So we'll start by sharing data that has been known to the transplantation community for a couple of decades now, the advantages of kidney transplantation becoming the treatment of choice in end-stage renal disease, where in comparison to dialysis, it offers improved survival, quality of life, and overall decreased healthcare expenditures. This being said, in the context of graft loss, however, there's a substantial increase in mortality, decrease in quality of life, and a substantial increase in healthcare costs. In this, with this backstroke, there has been an effort to survey the opinions of a variety of stakeholders in the context of transplantation to establish outcomes that are of most significant importance in transplantation, and graft health was deemed to be one of the most important ones. And unfortunately, where graft survival might be compromised often is in the context of immune-mediated injury. In this slide, I share with you an analysis that was conducted in Alberta, whereby patients who experienced graft failure and had preceding biopsy of the graft, there was an evaluation of the distribution of causes of graft loss. And in this setting, it was antibody-mediated rejection or probable antibody-mediated rejection that was observed in the majority of the patients. This was further noted to be more common in patients who were non-adherent to immune suppression. Antibody-mediated rejection is considered to be a dynamic and continuous process, eventually leading to chronic graft injury and loss. Starting with appearance of donor-specific antibodies, activation of complement, evidence of inflammation in the graft. In context where the injury is but temporary or acute, graft function could return to normal with somewhat minimal intervention. However, repeated injuries or injury that is gone unnoticed potentially could result in chronic graft dysfunction and eventually graft failure. In an effort to prevent antibody-mediated injury, every transplant candidate undergoes routine testing for presence of anti-HLA antibody. This informs a calculator or a score called panel reactive antibodies. This score ranges between 0 and 100%, providing an indication as to the proportion of the donor pool that one would be eligible to receive transplants from. So in a context of PRA 0, the entire donor pool could potentially be deemed compatible. But the larger the numbers of anti-HLA antibodies or the repertoire of anti-HLA antibodies, the smaller the potentially eligible donor pool a patient might receive a transplant from. The implications of higher PRA, so going from PRA 0 to 100%, has to do with access to transplantation. So the higher the PRA, the lower the likelihood that a patient will undergo transplantation. Alongside this observation, when considering mortality on the waiting list, the higher the PRA from 0 to 100%, the higher the likelihood of dying on the waiting list awaiting for a transplant. PRA is an important determinant, as I showed you, to access to transplantation and patient survival on the waiting list. But its main use is to inform immunological risk or to mitigate immunological risk. However, PRA on its own or the repertoire of preformed antibodies do not tell the entire story, in that PRA facilitates our efforts to avoid preformed antibodies. However, new antibodies could form post-transplantation. And where PRA potentially fails somewhat, molecular compatibility could contribute additional information. So how do we transition from the context of PRA to molecular compatibility? Every donor and recipient in preparation for transplant undergo HLA genotyping. HLA, this is an example of one such molecule, human leukocyte antigens, is like a barcode that each of us has and allows our immune system to differentiate between any structure that belongs to us versus not, such that an external virus, for example, would be recognized as foreign and would be attacked by the immune system. Similarly, a transplant would stimulate a similar response when recognized as different in the absence of immune suppression. So antibodies form to certain regions in the HLA molecules. So these regions are referred to as epitopes. The immune system recognizes a certain portion of the HLA molecule in this context, and antibodies might develop if the HLA of the donor is deemed different from that of the recipient. So every transplant candidate and donor, again, undergo HLA typing, genetic testing that eventually informs the appearance of these kinds of molecules or proteins. The genetic sequence can be transformed to an amino acid sequence. And what this slide is trying to show you, that with each modification of HLA gene, potentially this could translate to regions in the HLA protein that are distinct from one gene informing a different protein to another. And if these regions that are deemed highly polymorphic in the donor might differ from that of the recipient, an HLA mismatch at the molecular level would be informed, and this could result in development of anti-HLA antibodies. There's a scientist called René de Quesnoy who established this algorithm called HLA Matchmaker that has been used over the years to inform on the incompatibility at this level between donors and recipients and the likelihood of developing donor-specific antibodies and a variety of immune injuries. So how can we inform ourselves based on molecular compatibility on the risk of experiencing immune injury and graft failure? So molecular compatibility effectively allows us in a more sensitive fashion to estimate immune risk. In patients without preformed antibodies, in the context of these different polymorphisms between donor and recipient, despite the absence of antibodies, there could be a whole spectrum repertoire of risk against particular donors, depending on the degree of molecular incompatibility between a candidate and a donor that's being offered to them. Highly sensitized patients are basically, again, restricted with regards to the access of to transplants whenever the donors have HLA against which they have antibodies, but there's greater specificity with regards to estimation of immunological risks in this context. In this slide, I share with you analysis that we conducted several years back, where we looked at the likelihood of molecular incompatibility, again, to inform risk of irreversible immune-mediated injuries in the graft and graft failure. The graft failure outcome was studied in a retrospective cohort from the Scientific Registry of Transplant Recipients, and the immune injury was transplant glomerulopathy, again, a marker of chronic injury in the allograft. And what we observed in these two data sets, the latter being a nested case control study from a retrospective cohort from University Health Network, we observed that the higher the number of molecular mismatches, the higher the risk of experiencing both graft failure and transplant glomerulopathy. And when we looked at the subsets of these polymorphisms that were verified to result in an antibody response, quantitatively, the risk appeared to be more significant or more pronounced. So this provided a potential path towards informing risk in the context of transplantation and potentially avoiding a certain subset of these molecular incompatibilities, decreasing the risk of experiencing immune-mediated injury and graft failure when taken into consideration in organ allocation. In this somewhat complex slide, I represent to you a variety of strategies, a variety of repertoire of these molecular compatibilities that one might strive to match on. The epitype would represent all different types of molecular incompatibilities observed. On the right-hand side is the subset that has been verified by antibodies. What we can see over here, that the more restrictive the strategy, nevertheless, when you move from a smaller to a larger number of molecular incompatibilities, the risk of experiencing graft failure increases. Now, these analyses were done in a particular context. So the higher the molecular mismatch, the higher the risk of experiencing graft failure. And in this slides represent data from a male kidney transplant recipient who was 25 to 44 years of age with public insurance in the US, who had spent approximately 21 months on dialysis while waiting for transplantation, receiving transplant from a standard criteria deceased donor induced with an IL-2 receptor blocker and on maintenance immune suppression, including a combination of calcineurin inhibitor, but without steroids. So the importance of this case scenario is that, again, the repertoire of risk is informed biomolecular mismatch in this patient. However, different patients in the context of their age, their sex, their potential ethnicity, their transplant context, so the donor they get transplanted with, as well as the immune suppression that they are administered, all of these contexts could further modify their risk. So one might ask themselves, who may be the members of the population who could benefit most from molecular compatibility? So, or are there other parameters that could further increase the risk of experiencing graft loss that we should strive to optimize molecular compatibility within? So I will not go through all these characteristics that are represented here, but I will say that, for example, the younger the recipient's age group, the higher the risk of experiencing graft failure in the context of any given molecular compatibility. The choice of immune suppression is also of importance. So I mentioned in the best case that that patient did not receive steroids. So in the context of their molecular incompatibility, steroids would have conferred some protection against immune risk. Granted, the potential advantages of optimizing molecular compatibility in any given patient is the potential not to be as dependent on immune suppression in an effort to mitigate risk. With this, I will move to how organ allocation takes place. So currently in Quebec, for example, this is how the allocation rules work. First, there's verification that there is blood group compatibility between a potential donor and any of the waitlisted candidates on the list. Thereafter, there's identification of a patient who's potentially deemed of greater medical urgency. This is typically adjudicated by a committee. Thereafter, organ offers would be given to highly sensitized patients. You'll note that this allocation happens at a national level, one of the great Canadian successes, I would say, in the context of transplantation, the highly sensitized program. Moving forward, if there was no allocation in these categories, organs would be offered to combined organ transplant candidates, so heart and kidney, lung and kidney, for example. Thereafter, there's verification of a negative cross-match, both cellular when needed and primarily virtual cross-match, with allocation based on blood group compatibility of O to O, A to A, A to AB in the context of antibodies in the patient, similarly B to B and B to AB in the context of antibodies, and AB to AB. Subsequent to this step, the next priorities would be priority number 4, pediatric patients with some restriction with regards to eligible donors, pancreas kidney transplants, and finally, the remaining category, priority 6, waitlisted patients in whom the allocation is done based on a score. And importantly, this score takes into consideration both utility of the organ, and utility parameters here would typically be deemed compatibility at the antigen level, not at the molecular level, with regards to HLA-DR type, history of immune sensitization of the patient, but also aspects of, again, equity. So PRA could be one, but waiting time being another very important one. So with this introduction, I will invite my colleague and friend, Dr. Marie-Chantal Fontaine, to share some of the work that we've done in the context of informing ourselves on transplant professionals and patients' perspective on incorporating molecular compatibility into organ allocation.
Thank you, Ruth, for setting the table for the rest of the presentation. I would like again to thank the CDTRP for giving us the opportunity to present our work, and it's a real pleasure to present with my friend and colleague, Ruth. So as Ruth mentioned, You know, organ allocation vary across jurisdictions. She has presented, the kidney, the deceased donor kidney allocation in Quebec, but even, most of the jurisdictions, well, all the jurisdictions try to balance fairness while treating people equally. And when we are talking about fairness, it's treating people equally. So we are taking into account waiting time, but it's also to look at who are the worst off, and how can we advantage them. So taking into account medical urgency, people who are highly sensitized and who don't have many chance to be transplanted, ethnicity, we don't take it into account in our system, but sometimes it's argued that it could be taken into system where, because we know that minorities are disadvantaged in organ allocation, blood type, geography. And when we are taking into account medical utilities, when we try to match age between the donor and the recipient, when we try to match the predicted patient and graft survival, well, it is the premise or the rationale behind the kidney allocation system in the US. When we give points to HLA match, when we take into account the quality of life of the recipient, and we try also to avoid wastage or non-utilization of kidneys. So please, Ruth, next slide. So in the next two slides, I will present studies about transplant professional preference on organ allocation. Their preferences are important to elucidate since they participate in numerous committees to determine organ allocation scheme. So one of the studies conducted in more than 10 years ago, it was a qualitative study with 25 Australian nephrologists. And what they showed is that nephrologists thought that maximizing transplant survival and age compatibility were the most important criteria to take into account in deceased kidney allocation. Also, they mentioned that it's not only their decision how to allocate kidney, but also that we should bring external expert, patient, public to determine how to allocate kidneys since it is a public resource. More recently, there was also another qualitative study conducted with transplant professionals in Israel, and that showed that chance of receiving another donation was one criteria, meaning that if you have very low chance to have a second chance, well, like highly sensitized patients, well, you should be prioritized for a kidney allocation. Kidney allocation should take into account prognosis, waiting time, and recipient age. So as you can see, well, most of the transplant professionals are more focused on maximizing utility. So next slide, please, Ruth. And recently, another survey with Australian healthcare professional, it was a best worst scaling survey. Well, they showed that, the participant wanted to allocate kidney with the best predicted survival to patient with the best predicted survival, that they want to give priority for young recipients, maximizing graft survival, patient survival, and quality of life, minimizing waiting time, and trying to achieve equity in access for Indigenous candidates. I think it's very interesting because Australia has also important Indigenous population, so as in Canada, so that's something that maybe we should think in the future to take into account. So yes, thank you, Ruth. So, well, Ruth has very well explained what is molecular matching. It is very interesting, but there are some ethical issues. Of course, we think that there's benefits for the patient and the society because there's a potential to increase patient survival and reducing graft rejection, but there's still a lot of uncertainty. And probably the major issues, the fairness issues, is there a risk of decreasing access to kidney transplantation for patients with rare epitopes? So we can think about patients from ethnic minorities that could be potentially disadvantaged in their access to transplantation. So the objective of this study that I'm presenting today, which is part of the larger project Can Prevent AMR, is to gather key stakeholders' perspective on molecular matching and precision medicine in kidney transplantation. So who are the key stakeholders? They are transplant professionals, transplant candidates and transplant recipients, and HLA experts. Today, I will focus on the result of transplant professional. This was recently published on Transplantation Direct if you want further details. So it was a qualitative study. We conduct individual semi-structured interviews with kidney transplant professionals. We address the following themes in the interview grid. So knowledge and perspective on the current allocation system, the role of molecular matching in deceased and living kidney donation, informed consent, and molecular compatibility. We use a qualitative description approach as a framework for the analysis, and also we use the software NVivo. So we conduct interviews with 17 transplant professionals. As you can see, it was well balanced between sex. We had more white participants. They were mostly adult transplant nephrologists, and they were from all the province of Canada except the Atlantic province. However, we had a lot of people in Quebec. Maybe it is because Ruth and I were from Quebec, but otherwise we had some representative of different provinces. So in the next slide, I will present the important themes that we found in the interviews. So first of all, participants attribute really importance of fairness and equity in kidney allocation. For the majority, fairness and equity are more important than medical utility because fairness and equity are of paramount importance to maintain trust in the allocation system. And the system should strive to increase access to kidney transplantation. So I will present some quotes because in qualitative study, we present quotes. So for one transplant nephrologist, it would say, so for me, maximizing access to transplantation outweighs maximizing the longevity of a transplant kidneys. It's more important. Next. I think from a programmative perspective, the health system needs to be biased toward fairness. And so, as it relates to the default position, it should be to ensure that everyone has similar access to transplantation and that the choice to wait longer for a better matched kidney or a better quality kidney should be the choice of the transplant candidate, not of the system. It was a pediatric transplant nephrologist. Next. For some participants, fairness is important as medical utility. Both principles are important and should be balanced. But it's trying to ideally strike a balance between equity and utility, as they say, and the nuance are challenging as to, where you put those cutoffs. So yes, expected survival has some weight, but it is hard to predict on an individual basis somebody's anticipated survival and quality of life post-transplant. Next. I think a balance needs to be maintained because if we just consider graft survival, we'll no longer transplant older people, and older people have the right to transplant as well. So next slide. One question about precision medicine, for most participants, it is really a promising innovation because it could increase the medical utility of a limited pool of organs. Next. I think that the concept is obviously very attractive. So, if we back it up, so the premise here is that unlike serological typing of HLA antigens, that matching on epitope load or epitope mismatch may allow us to increase utility from the available organ supply. And here's the key: without exacerbating disparities that are linked to genetics, which are ultimately linked to race. And so that's really the issue. If we can achieve that, then I think the system is potentially useful. Next. Molecular matching also could reduce AMR, antibody-mediated rejection, and the need for immunosuppression. Basically, I think it's great, especially if we can have a kidney that can be better matched, meaning fewer rejection, fewer immunosuppressants. Molecular matching could be used for patient monitoring. If we see that there's a big load of mismatch, maybe we could adapt our approach. Molecular matching could help to choose among many living kidney donors, and it could be useful in kidney pair donation when there are many options. And there's also benefit of molecular matching for young recipients. We know that they are at higher risk of rejection because of non-adherence. So if they can receive a better matched kidney and decrease the risk of rejection, probably it's beneficial for them. However, that being said, there are some concerns with precision medicine and molecular matching. First of all, increased waiting for times for transplant candidates and the potential negative consequences for patients from disadvantaged population. And we know for a variety of sort of socioeconomic and cultural reasons that there are certain minority groups that are underrepresented in the donor population. And that means that certain minority group recipients will be disadvantaged if we prioritize too much. And also the issue of informed consent. Molecular matching is a complex issue, so we have to provide sufficient information to our patient that they will be able to consent. So we need to develop educational tools. And, you know, educational tool in lay term. And also the next quote, I think if we are going to provide them with too much complex information, they will get confused and maybe a little scared to the point that they may actually run away from transplantation. So I hope that someone will be able to maybe create a cartoon on HLA. So I really like the idea. I think I would benefit from a cartoon on HLA to better understand all these complex issues. Next slide. Also, one participant also raised concern about the operationalization of this new allocation algorithm, you know, the cost and also all the lab facilities. Ruth, can you put this, I think we will get there, but I think there is, as I said, when the labs are already struggling financially to do the testing we are doing just now, it's tough to see us getting there in the next year or two, and the technology is still evolving. Participants also formulated recommendations if we are going to implement molecular matching in kidney allocation. First of all, there should be a maximal waiting time for a molecular matched kidney. So people told us, you know, you could wait for a certain time for a really well-matched kidney, but after a time, if you're not transplant, there's probably much more benefits to get a lesser matched kidney. So the idea of 5 years was sometime mentioned. So transplant nephrologists would say, I think that for people who have waited 5 years, it's their turn. So I think that could be integrated, but with an eye to ensuring that there's a maximum number of points they can collect, and that this doesn't hinder people who have been waiting a long time for a kidney, even if it's not as well matched. So respect a reasonable wait time while better matching kidneys for others. I think that could be acceptable. Next. Also, in order to maximize the matching, molecular matching should be implemented at a national or international level. Sorry for the typo, but such as for the HSP. Because again, absolutely, that there's a risk that if you don't have, or you are going to wait longer and longer and longer and not get your match. But if you could expand the donor pool to the entire country, then you are just increasing the number of lottery tickets everybody has to potentially get those epitopes match. And also, it's important to engage stakeholders and to have a transparent policy. So one participant would say, bringing all the relevant science and data to the discussion, plus having all the relevant stakeholders at the table, plus making sure all the relevant information is intelligible and can be used by all stakeholders. Because if the physicians are the only ones who understood that part, then we fail. We have to also to make sure that patients also understand. So next. This is the first study to report Canadian transplant professional perspectives on molecular matching in kidney transplantation. And well, it's interesting because transplant professionals' perspectives are aligned with the results of pan-Canadian deliberation, where participants also supported molecular matching. This is interesting because in our study, the issue of fairness and equity was really a concern, and participants had some preference towards fairness and equity, and it's different than, you know, transplant nephrologists or transplant professionals' preference reported in previous studies. And in our study, increasing waiting time, disadvantage some population, and adequately informing patients are major concern. Next. Well, limitations. Well, participants are from all provinces except the Atlantic province. And also transplant professionals' perspectives are based on their own knowledge of molecular matching. So they didn't have any formal education on molecular matching before their interviews. And of course, there's always the social bias, social desirability bias that could be there with qualitative study. Next two slides, just few words about the study with patient perspective. So we have conducted interview with 21 kidney transplant recipients, kidney transplant candidates, and caregiver from the CHUM and the MUHE. You have the detail of the participants and the major themes. Well, participants had trust in healthcare professionals and ODO to develop a fair allocation system. They were ambivalent towards molecular matching and precision medicine. They were ambivalent because, well, on one side, it could improve graft survival, but on the other side, there's the impact on the waiting time and access to transplantation. The importance, of obtaining informed consent. And again, the idea of a maximum waiting time for molecular matching. So I'll let Ruth, I think I will be glad to hear for you how we move forward with those results. So Ruth, it's your turn.
Thank you, Marie-Chantal. So with this additional information on the perspective of clinicians, we move forth, and is an outline of an effort that has been going on over the past several years, a lovely Canadian collaboration with different arms of this activity taking place over the past several years, as well as collaboration and extension internationally, where people come together to truly inform how to better contribute to transplant patients.
Oops, Ruth, we're not hearing you anymore.
In fact, capable of having patient-level genotyping done in advance of transplantation. There's effort and must progress in providing accurate genotyping information for donors as well. The identity of the molecular parameters that we want to ensure that we match upon, this repertoire has been a topic of discussion on an ongoing basis. There have been iterations of the algorithm, of the HLA matchmaker and algorithm, and in recent years, again, various stakeholders have come together in an effort to standardize the nomenclature and identify the incompatibilities that are of most importance to match upon. And again, this introduces the next stage. Given there's so many incompatibilities potentially that one might want to match upon, it is important to figure out where we want to start, what is a true priority, and where there might be potential restriction in access to transplantation, that this indeed is a worthwhile wait to access a compatible donor. So efforts with this regard are ongoing. It requires collaboration between clinical researchers that study these data at the population level. But very importantly, this is also an effort that needs to be confirmed at the level of the lab. And such efforts indeed are underway, where previously not antibody verified molecular incompatibilities have been recently deemed to induce antibodies. So this effort, again, is ongoing. We learn from professionals' perspective, as well as, and this is a nice opportunity to acknowledge effort that has been led by Brian Sterling from BC and his team to inform on population-level preferences that complement very nicely to the information Marie-Chantal shared with us today with regards to ensuring flexibility and in organ allocation and equity in access. So there are parameters that the public also highlights, context of medical emergency. While there is wide support of incorporating molecular compatibility into organ allocation schemes, there are nuances where these kinds of priorities might be relaxed to facilitate access to transplantation when there is an urgent need. There is an effort to develop a model with economic evaluation underway that will further, again, inform where it is the most cost-effective to implement these strategies. And finally, any implementation of policy requires tools to be available. And tools are now available in development and in preparation for submission for peer review. So there's a calculator that allows us to inform an individual at an individual level, they're likely of accessing molecularly compatible donor given the donor pool that has been present in recent years. There's the CanMatch calculator that allows us, that is effectively an algorithm that allows us to illustrate the likelihood of allocating organs in with a molecular compatibility philosophy, and what are the implications to access to transplantation. There's much interest in implementing these tools in a context that is already, to a certain extent, optimized with regards to compatibility and allows flexibility to maximize molecular compatibility within the living donor paired exchange program. And there's research underway with regards to opportunities for implementation, again, to facilitate access in the context of highly sensitized patients. Alongside all of these tools, ongoing education, again, transparency with regards to the implications to access to transplantation, and accountability in the form of reevaluation in a context where policies may be implemented such that we can reflect together as a community on once the change is implemented, what do we observe if there's new inequities that have been formed that one could not necessarily predict in advance, such that we can ensure that as a community, as an organization, we learn and again, improve upon our patients' experiences and outcomes. And with this, I would like to acknowledge the funding organizations that supported this work. And last but not least, members of the Genome Canada Transplant Consortium who have at various stages contributed to this. Specifically, I'd like to acknowledge Doctors Keon, Caulfield, Brian, the co-leads, as well as, again, this large group of scientists, patient partners, and various stakeholders at truly various levels who contribute on an ongoing basis to this effort. Thank you so much, and I'll hand over to Todd.
Thank you for that excellent presentation. We want to leave time for a couple questions. So if anyone has any questions, please do raise your hand. I actually see already that Stephanie, that you have your hand up. We'll start with you. Oh,
no, it was just a clapping hand.
Oh, okay. Were there any questions that anyone had for our guest speakers? I'm just checking the chat to see if there's any. Do the two of you have any final thoughts before we sign off? I'm not seeing any questions at the moment. Oh, Sean,
I can pose a question, Todd, if you want.
Sure.
So Ruth and Marie-Chantal, that was fantastic. Thank you so much. I got to be on one of the sessions, the focus groups that Paul and his group were hosting out in DC on this topic. And one of the themes that came up, and I was wondering if it was common with the nephrology group as well, was the trade-off. You have predictive models that you may wait X, Y, Z depending on your CTRA and things like that. But if I go the molecular route that is outlined here versus staying on the existing route, the trade-off of wait time, but also potentially a 25-year kidney instead of a 10-year kidney, or of course it's not hard and fast science, but the models are getting better and better. So I think part of the informed consent needs to include that trade-off of, yeah, you might wait longer, and that wait might be 3 to 5 years, and then your informed consent is part of deciding, well, is it worthwhile being on dialysis or prolonging your current situation for that? Did that come up in the nephrology side as well? Like, what predictive models can you give to help in explaining the opportunity cost to patients?
Yeah, it was mentioned. I didn't show all the result, but it was mentioned by the transplant nephrologist. Well, the need to have precise data to present to our patient, to tell them, if you wait for that kind of for a molecular match kidney, you'll wait for, well, but it will increase the chance of it will increase your graft survival by X, Y, Z. So the need to really have some, clear data to present to the patient to make him informed. But there was also the issue at some point for most of the clinicians, it was too long waiting, they said that there was no advantage. And the 5 years, I don't know why the 5 years was so, but it's true, that's really a long time for our patients to wait for kidney transplant. And 5 years in dialysis, it could be really detrimental for all our patients. So That's why probably at that point, it was like a trade-off after that, probably go for normal allocation where your time spent on dialysis will make you a priority on the list. So
yeah, and well, the other part that you had in your presentation, I think, which is pretty key, is not just the time that the organ might last, but also the potential for reduced immunosuppression. So I know, Todd, you can probably speak to this too, but those are important considerations for those of us living as immune compromised people for life as well. So that was fantastic. Thank you.
But something that was not raised in the interview is probably also, the impact of age. Maybe if you're 70 years old, it's not worth waiting for a molecular match kidney, because what you want is to be relieved from dialysis. But if you're 21 years old, probably it's worth waiting for a molecular match kidney. But that was not mentioned in our study, but that's probably something also worth considering.
The rebuttal for that would be, I will say, just for the purpose of discussion, and this is why this topic is about personalizing care. If there is a patient of age who is likely going to need reduction in immune suppression for whatever reason, for frailty reasons and so on, there too, there might be shall we say, a certain advantage to molecular compatibility, albeit the strategy should certainly be sufficiently efficient that the compatibility offered would be worthwhile with regards to any kind of protraction of waiting time. Just as a context, if we reflect on it very briefly, I'll say the following. Eventually, there's no philosophy that would allow organs to be discarded. So at a waiting list level, the overall waiting time should remain the same. What we need to make sure is that we can optimize molecular compatibility with the appropriate effort, and at the same time taken to demonstrate that other variables of importance for compatibility, like age, are not compromised. So some work, again, that hopefully will be ready to be shared soon, so we can have an update discussion on this topic. And thanks, Sean, for a great question.
We have more questions in the chat. I'm just mindful of the time. Are you both okay saying an extra couple of minutes?
Yes, it's okay for me.
Okay. So there was a question, sort of actually two questions from somebody. The first question is, this person says, if the psychosocial risk is important as a risk for the graft and patient survival.
Of course. Of course, when we assess a pre-transplant patient, we also have to assess all the psychosocial environment, and to help our patient to be a candidate, we try, it's not a contraindication, but that's something that we want to work with the patient and other transplant professionals, psychologists, social workers to help our patient to access to kidney transplantation.
With your permission, Marie-Chantal, I'll add to that, in a context where access to immune suppression is dependent on one's socioeconomic context, certainly we see the impact of this. Again, thankfully, we're in a context where this should not be the case, but nevertheless, even in a more supportive context, patients do pay substantial amounts of money out of pocket, and this certainly is not to their advantage. So whatever we can do, again, to facilitate access to services would be of benefit, where, again, molecular compatibility might be an advantage if we reflect on it in a context where monitoring might be more challenging, a patient in a more distant context, where their access to these kinds of services might be more limited. Certainly, there might be an advantage to greater molecular compatibility as well. But again, more work to be done in that context.
Thank you for that answer. I see our moderator has dropped off, so I will take over for this. Katie, you had a question. Did you want to ask it?
Sure. Yeah. Thanks, Erica. Thanks, Marie-Chantal. Thanks, Ruth. It's nice to see you. Thank you for such a good presentation. I learned a lot today. It looks like you've done a lot of work and have quite a bit of work ahead of you. What does your next couple of years look like? Like, how are you going to prioritize all of the things that you need to do to get this from an idea into practice? From a good idea into practice.
So maybe I'll take this on first. So the calculators, I think, are important. So those have been developed and implemented in regional data sets. So one would want to implement them externally as well. For example, CPIE has been implemented in a variety of data sets. There's a national data set that we want to use as well for this purpose to see if further one could expand, again, access to transplantation thanks to national organ sharing. I think the modeling that are underway, the economic evaluation that's underway to complement all of these calculators and data that has been generated in recent years, again, at a multi-center level, so more data to be shared with everybody. There's an abstract that one of my graduate students submitted to the Canadian Society of Nephrology, and we'll share some more certainly at the Canadian Society of Transplantation coming up. The economic evaluation, again, highlighting where the thresholds lie, where the advantage continues to be present and what context might not be optimal. Important work also will need to be done because we cannot match on all molecular incompatibilities. Again, we're outlining strategies where we would feel comfortable as clinicians to prioritize. So the verification of incompatibilities that are resulting in immune injury, so subset of antibody verified eplets that have been deemed to be of increased risk would be a nice strategy to both ensure feasibility as well as, again, should be deemed justified in an effort to optimize graft utility. So this is where much of the effort is underway and will be shared, and we'd love your thoughts about these efforts in the coming months. Thank you.
You're welcome. Sean put a comment in the chat here. What does your comment say, Sean?
Oh, it's not a question. It's just like if you're talking priorities, it seemed to recall that lab readiness to do molecular testing was a big potential barrier because only 2 or 3 labs could do it as of a couple of years ago. I think Calgary, Montreal, Toronto, and I think Rob could do it out in Halifax, but using a modified method. But many other labs were out in the dark. So doing on-demand testing for deceased donors in particular was going to be a challenge.
So noticing that there's no more questions, I want to state that in the chat, there's some excellent comments from our other other researchers saying that this is very exciting and encouraging and important work. So with that, I will close the session, if that is okay. So I want to thank everybody for their questions and their comments that they mentioned today. Dr. Marie-Chantal and Dr. Ruth, on behalf of CDTRP, thank you very much again for presenting. It was wonderful having you both. If anyone has any additional questions or comments, you can message me at ekcroft@cdtrp.com, and I will relay them to these presenters. I would also like to mention that all participants will be receiving a very short survey. It takes about 2 minutes or so. And if you could fill them out, it'd be really appreciative for us. On that, thank you, everybody, and enjoy the rest of your day. Take care.
Thank you so much.
Have a nice day.